Hello everyone, I am Dr. Simone Atkinson and today's lecture is on a vital topic, electrolyte imbalances and how to begin to master this challenging topic in a much easier way. So my aim today is to go over the general concepts so that you can get the most test questions correct, whether you're doing an NCLEX exam or on one of your nursing exams. So understanding electrolyte imbalances used to be really tough for me, but I believe I found a way that is more straightforward, and it's a way for you to recall this very complex topic without very much memorization at all. So today we'll cover the highlights of the most important signs and symptoms of electrolyte imbalances so that you can remember them also without much hassle or without too much memorization. So while we do not want to memorize lists and lists of different states of electrolyte imbalances, you do need to understand that memorization to a certain degree is a powerful tool so that you can have quick recall of information when you are doing an exam. So you may have heard of these 3 sentences that capture the essences of electrolyte imbalances that are used as valuable memory aids. The first is kalemias follow the prefix, but heart rate and urine output go opposite. Calcemias oppose the prefix and magnesiemias oppose the prefix. So those 3 sentences about electrolyte imbalances have crossed my path before, yet even as I waded through numerous symptom descriptions in the books, my mind just couldn't grapple and link them all together. So today I am here to try and bridge that gap for you because I believe I have figured that out. So we will embark on a focused lesson that's designed to solidify your comprehension of the highs and the lows of electrolyte imbalances, and the goal is to not have to memorize every single list of each state of a hypo or hyper scenario. So to start off, there is some level of memorization that you do have to do, and that involves grasping the normal levels. The normal values and knowing them is absolutely crucial for you to do well on your exam, in the essence of that you will not have to be worrying whether a level is considered high or low. So rapidly identifying high or low levels during an exam will be essential and will help you, as well as probably give you a lot less anxiety. So I find it's effective to memorize the electrolyte ranges of the extracellular space from the smallest to the largest. So once these normal values are ingrained, identifying abnormalities will become much easier. So here's a handy memory technique that I use. So for magnesium, the normal is 1.5 to 2.5, and just imagine a magnifying glass making things 1.5 to 2.5 times larger. Then you have phosphorus, right? So think of for us in the name. 4 has 4 letters and us has 2 letters. Just remember to add 0.5 to the remainder of the range. And of course, 2 comes before 4, so that's 2.5 to 4.5. Next, we have potassium. So recall that bananas are rich in potassium, and they're usually bought in bunches of 3 to 5. So the range for potassium is 3.5 to 5. Calcium, I associate it with a gallon of milk weighing about 8.5 pounds, and then I add 2% milk, so I have 8.5 to 10.5 for calcium. Chlorine, I just think of a hot tub, and you think of the temperatures of a normal hot tub of 95 to 105 degrees for chlorine. Then last you have sodium. Just remember the odd numbers in sodium, OD, odd. And remember odd numbers 135 and then add 10. So sodium is 135 to 145. Also, you'll notice the alphabetical order of the first 3. Magnesium, M comes before pH, phosphorus, and pH comes before PO, potassium. So you first have magnesium, then phosphorus, then potassium in that order for the ranges. And then the last 3, you have calcium, which will come before chloride. Ca comes before CH, so that you can remember calcium is the 8.5 to 10.5, then chloride is 95 to 105, and then sodium is last. So by the time you face questions or take exams like the NCLEX or HESI, you should have these normal values at your fingertips. So as we navigate through the lessons of electrolytes, I just encourage you to adopt a very broad concept for each one and what they do. Because the truth is, attempting to memorize every detail of each electrolyte will probably be very overwhelming and time consuming. And theoretically, it is possible, but it's not necessarily practical. So in the nursing field, questions often center around what are the overarching themes or signs and symptoms of each of the different electrolytes. So that's where our focus should lie, and just grasping the general information that holds true for most cases. So let's briefly outline the themes for each electrolyte. First is magnesium, and magnesium is associated with muscle relaxation. So magnesium is for relaxation. Then there's phosphorus, which is the opposite. It's linked to muscle contraction. So magnesium for muscle relaxation, phosphorus for muscle contraction. Then there's potassium that plays a role in intracellular excitation. Remember, potassium is the highest concentration of electrolytes inside the cell. So potassium plays a role in intracellular excitation. Then there's calcium, which is significant for bones and muscle excitation. And chloride pertains to cellular excitation, but that is usually connected mostly with sodium and potassium. And then finally, we have sodium, which is a key player in extracellular function. Remember, sodium is primarily concentrated in the extracellular fluid. So if you recall one of the 3 sentences to capture the essence of electrolyte imbalances in the beginning of our lecture, magnesiemias oppose the prefix. So this means if you have hypomagnesemia, symptoms are fast. And if you have hypermagnesemia, symptoms are slow, because magnesiemias oppose the prefix. So when we first focus on magnesium's core function of muscle relaxation, just visualize a scenario where you administer a significant amount of magnesium to a client. So what's the likely outcome? The muscles would be profoundly relaxed, creating a state of heightened relaxation, correct? So this aligns with magnesium's general theme of inducing muscle relaxation, and high magnesium relaxes muscles. However, in cases of low magnesium levels, the opposite will occur. Muscles become excessively excited, leading to increased deep tendon reflexes, seizures, tachycardia. So essentially, everything gets amplified with the low magnesium level. So a magnesium level below 1.5 triggers a cascade of excited events, right? So increased deep tendon reflexes, tachycardia, seizures, laryngeal stridor, muscle twitching, tremors, tetany, diarrhea, nausea and vomiting, and positive Chvostek signs. So these are excitable symptoms or excited symptoms. So given these symptoms, it's evident that the muscles are on high alert when you have low magnesium levels, and the remedy to fix these symptoms would therefore involve administering magnesium to restore calmness to the muscles. So then if we shift to the focus on hypermagnesemia, the theme remains muscle relaxation. So the theme says magnesiemias oppose the prefix, so hypermagnesemia will calm or slow things down. So all muscles exhibit relaxation, leading to decreased deep tendon reflexes. Excessive magnesium can result in respiratory arrest or cardiac arrest because the muscles are all so relaxed. So the client might become extremely relaxed to the point of somnolence and displaying weakness, lethargy, and possibly even falling into a coma. So in practical applications, magnesium also finds its place. It could treat, for example, preterm labor to calm down an overactive uterus, or magnesium could be used, not could be, but magnesium is used to address torsade de pointe, which is a very specific type of polymorphic ventricular tachycardia, and it works by pacifying the heart's rhythm in order to break the torsade. So magnesium calms things down. Just on a side note, just remember too that the antidote for hypermagnesemia is calcium gluconate. So if at any point we ever gave too much magnesium to a client, we would use calcium gluconate as an antidote for the hypermagnesemia state. Now, phosphorus is another key electrolyte to hone in on and etch into your memory. And the standard laboratory value falls between 2.5 to 4.5. Now, phosphorus primarily functions in muscle contraction. So this is different than magnesium, which was for muscle relaxation. Now we're on to phosphorus, which is for muscle contraction. So think of it as a conductor for muscle movement. So if the level is low, muscles will tend to relax. Conversely, a high level can induce tetany. So phosphorus is the contractor, where we saw that magnesium was a relaxer of muscles. So with low phosphorus levels, the symptoms would include reduced muscle contractions, potentially leading to complications like decreased myocardial contractility, possibly leading to symptoms such as heart failure and shock, respiratory muscle fatigue, which can escalate into respiratory failure, hypoactive bowel sounds, diminished gastric motility, and even an ileus. So everything slows down with low phosphorus levels because phosphorus is needed for muscle contraction. So on the flip side, hyperphosphatemia manifests as signs of hyperactive muscle contraction, such as irregular heart rate and conduction disturbances, such as tachycardias. You could see paresthesias, tingling and numbness, and even tetany that's marked by muscle spasms, a positive Chvostek and a Trousseau sign indicating neuromuscular irritability. So phosphorus will cause irritability of the muscles because it's for muscle contraction, whereas low levels of phosphorus will have decreased mobility and decreased muscle contraction. Of note, it's also worthy to note that elevated phosphorus levels are often seen in clients with renal failure because they're unable to excrete the phosphorus from their system because their kidneys are not functioning. Now let us focus on potassium. The accepted lab range stands between 3.5 to 5.0, and its role lies in intracellular excitability. So consider this: an excessive potassium is trapped within the cells, would trigger some serious issues. So also remember that small shifts in levels can lead to significant consequences. When potassium comes to mind, I want you to always think arrhythmias will follow. So this mineral is extremely sensitive to the heart's rhythm. So the memory trick reminds us that kalemias will follow the prefix except for heart rate and urine output. So if kalemias follow the prefix, if we have low potassium levels, we would see faster heart rates. And if we have high potassium levels, we should normally see lower heart rates. There's just one exception to that, which would be ventricular fibrillation, which is commonly seen when we have very high levels of potassium. So low potassium levels result in decreased intracellular excitement. So that will be accompanied by paresthesias and tingling or numbness. And the cardiac tissue experiences reduced excitement, leading to decreased contractility. So visualize the T wave, which represents ventricular repolarization or relaxation. And that T wave will reveal some insights with the hypokalemia because the T waves are flattened, and potentially we can also see a U wave at the end of the T wave with hypokalemia. So the client will also experience a weak, thready pulse. The cells are not excited, and the client could exhibit signs of lethargy and weakness and decreased peristalsis that can lead to constipation. So now shifting to high potassium scenarios, the effects can range from the opposing effect, which is a slow heart rate. Tall peaked T waves are seen with hyperkalemia, and we can also see severe conditions, as mentioned earlier, like ventricular fibrillation. So there is intercellular excitability. So the client may experience hyperactive bowel sounds, diarrhea, muscle twitching, and irritability. So remember that hyperkalemia frequently underlies arrhythmias, in particular ventricular fibrillation is the most lethal. So please be mindful anytime we think of potassium levels, be mindful of your arrhythmias. Because remember, potassium is responsible for intercellular excitability. So I don't want to move on without reviewing a few fundamental rules. So a fundamental rule to remember is never push potassium IV. So instead, adhere to the IV fluid administrations that's tailored to potassium levels to ensure that it's a safe and effective treatment approach. So when determining the dosage of IV fluids of potassium levels, be very cautious. So if you're faced with potassium levels exceeding 40 milliequivalents per liter as an order, it's extremely important that you clarify that with the physician or the healthcare provider, because more than 40 is too much. So remember, potassium will send your patient into fatal arrhythmia, such as ventricular fibrillation. So never ever push potassium IV, and it should always be hung on with a pump so that you can control the administration of the potassium. So with elevated potassium levels, we know that we can have severe consequences on the heart's function. So when it comes to rapidly lowering potassium concentrations, administering IV insulin and hypertonic dextrose solutions can trigger a brief relocation of the potassium back into the cells in order to decrease the potassium level in the vascular space. So the impact of glucose and insulin treatment can become evident in approximately half an hour, with effects lasting several hours. But remember that this is only a temporary measure. So in addressing prolonged potassium imbalances, a different medication, which is K-exolate, would be used. It's a therapeutic agent that helps to facilitate the exchange of sodium and potassium in the GI tract. K-exolate is a resin-based medication, and as it exchanges sodium for potassium in the GI tract, it'll promote the elimination of excess potassium through fecal excretion and gradually will restore a healthier potassium level over time. But this does take a lot longer than the immediate effect of D50 and regular insulin, which would have a more immediate effect, and then K-exolate would be used for a more long-term controlled process of decreasing a client's potassium levels. So administering the K-exolate is designed to address the elevated potassium level over time. However, it will further cause a different problem, which would be potential hypernatremia. And that is because the hypernatremia arises from that potassium-sodium exchange mechanism that happens in the GI tract, which will lead to a surge in serum levels of sodium as the excess potassium is being excreted through the feces. So to rectify this hypernatremia, it would require the administration of intravenous fluids in order to reestablish the equilibrium. So the normal calcium range rests between 8.5 to 10.5, and the mineral resides within both bones and tissues. But before discussing the signs and symptoms, I want to just make an important note on how calcium is measured in the blood. So when measuring calcium levels in the blood, it's important to realize that there is an influence of albumin, which is a protein that binds to the calcium. So calcium in the bloodstream will exist in three main forms: bound to the proteins, primarily albumin, complexed with other ions, as well as it's in its free or ionized form. So these three different forms have varying degrees of biological activity. However, there is a catch. So if a client is in starvation mode or has liver disease, they're not able to produce enough albumin, and that would lead to lower levels of albumin in the blood. And since most calcium is bound to albumin, a decrease in the albumin can lead to lower total calcium levels, even though the biologically active ionized calcium that we are more concerned about may actually remain unchanged. So in scenarios like this, where you have someone with liver disease, they could have a skewed impression of the true calcium status. And that is where the concept of a corrected calcium will come into play. A corrected calcium is calculated to adjust for these variations in the albumin level. So by correcting for the albumin concentration, the healthcare provider can have a more accurate estimation of the ionized or the biologically active calcium, which will provide a clearer picture of the client's calcium status. So in essence, just understanding the interplay between calcium levels and albumin and the potential impact it has on making decisions in situations such as liver disease or malnutrition is vitally important. So calcium is responsible for managing neuronal excitation. And when I say managing, I'm referring to it calming things down. So in a situation, if you have hypocalcemia, there is an elevated excitability because you don't have calcium available to calm things down. So the client will exhibit excess muscle contraction and diarrhea, muscle spasms, tetany, trousseau-Chvostek sign, seizures, and prolongation of the QT interval. Now, on the opposite end, with hypercalcemia, there is decreased muscle contraction, there is constipation, and a shortening of the QT. So to decrease calcium, if you have an elevated level, you can give meds such as bisphosphates, calcitonin, or glucocorticoids, as well as loop diuretics. And in renal failure situations, dialysis may be required. So functionally, calcium plays a role in the extracellular fluid where the significance lies in managing the neuronal excitability and the stabilization of the channels, particularly within cardiac myocytes. So the stabilization mechanism is truly crucial because it helps to achieve relaxation, thus preventing the occurrence of things like tetany, especially in the heart. So calcium will serve as a vital factor in achieving the relaxation and help to prevent tachyarrhythmias. And this is why we give calcium for conditions such as hypocalcemia to treat conditions of the prolonged QT intervals in order to prevent dangerous arrhythmias. So calcium helps to calm things down. So since calcium will relax the heart muscles, excess calcium could not only lead to irregular arrhythmias and decreased contractility of the heart, but also bradycardia and even cardiac arrest. So it's important to note when encountering symptoms that might stem from various electrolyte imbalances, there has to be a strategic approach to the problem. So consider the following guidelines to help navigate through this complexity. So first, you want to identify the source. So acknowledge that symptoms might arise from different electrolyte imbalances, but precision is going to be key. If you have a nerve or a skeletal muscle involvement, whenever you have nerve or skeletal related symptoms that arise, focus more on calcium levels. Calcium plays a vital, critical role in the neuronal excitations and the skeletal stability. When you have general symptoms and blood pressure, so for example, for a broad spectrum of symptoms, particularly those that are affecting the blood pressure, then turn your attention to potassium. So potassium's role in intercellular excitability will make it a prime candidate for more generalized symptoms or blood pressure symptoms that are identified. So just remember, potassium addresses intercellular excitability and broader symptomatology, whereas calcium will target neuronal excitation and issues related to nerve and skeletal function. Now, chloride is responsible for cellular excitation, but given that chloride complications are really the central concern, I will allocate just limited emphasis to chloride in this presentation. And I just want to say that chloride related concerns are predominantly going to arise in conjunction with electrolyte imbalances involving sodium and potassium. So that is where we will continue to focus. So with sodium, to keep things simple, we start with the normal range of 135 to 145. Sodium is responsible for exciting things outside the cell. It's the most abundant extracellular ion, and it's responsible for extracellular excitability. Now, sodium is a little weird because it's really sensitive to fluid balances, and it's very sensitive if the client has extra fluid volume or no fluid volume. So sodium is always trying to create a state of homeostasis. So a low sodium level will show very little excitement. So you would see muscle cramps and confusion, generalized weakness, or typically the same signs and symptoms of, say, fluid overload. So there is also a nuance with sodium that you need to know, because you can have hyponatremia if you have a low amount of sodium, or if you have too much fluid and a low concentration of sodium, which is called dilutional hyponatremia. So this dilutional hyponatremia can be seen in clients who drink way too much water, and this situation causes the sodium level to be diluted and the sodium level will drop. So they would be treated with medications such as diuretics and mannitol to get rid of the fluid, versus being given hypertonic saline solutions to fix the low sodium level. So when you think of low sodium levels, I want you to think of signs of hyponatremia related to overload, having too much water on board, where the clients are confused and weak and they have a headache and they can even have seizures. Now, with large amounts of sodium, the client exhibits signs and symptoms of dehydration. The signs and symptoms of hypernatremia coincide with dehydration, and the client has symptoms of thirst and have a hot, dry, flushed skin because they have too much sodium. They're dehydrated. So if you look at the signs and symptoms of hypernatremia, you can recall them by remembering the signs of dehydration. They're thirsty, dry, flushed skin, decreased urine output, fatigue, they're tired, they have an increased heart rate, they're confused, irritable, they can even have also seizures and coma. Now, if you look at the signs and symptoms of hypernatremia, you may also see that there is an overlap with some of the symptoms of hyponatremia. So with both hypo and hypernatremia, you can have symptoms of confusion, altered mental status, weakness, and seizures with both. So just try to recall the symptoms of in terms of whether it's fluid overload for hyponatremia or dehydration for hypernatremia, and use that as the memory aid for sodium imbalances. Now, there's an intriguing connection between hypernatremia and diabetic ketoacidosis. So DKA, which is a complex metabolic disorder, can lead to hypernatremia as a consequence of the dehydration that it induces. So here's the rationale. DKA involves elevated blood sugar levels and the production of ketones. So the body responds by increasing the urine output to flush out the excess glucose and the ketones. And this intensifies urination that leads to significant fluid losses, and it results in dehydration. So as fluid is lost, the relative concentration of the sodium in the blood increases, thus hypernatremia can ensue. And this phenomenon occurs because the sodium level remains the same while the overall fluid volume is decreasing. So remember, hypernatremia is associated with DKA, and it stems from the dehydration process that is inherent when this condition happens. So there are three other scenarios that alter our sodium balance. The first is syndrome of inappropriate antidiuretic hormone, or SIADH. So this is characterized by excessive release of antidiuretic hormone, which leads to an increased water retention by the kidneys, and this water retention therefore dilutes the sodium levels in the blood, resulting in hyponatremia. So the body's response to fluid overload is skewing the sodium balance. Next is diabetes insipidus. With diabetes insipidus, it represents a contrasting picture, because in this condition, insufficient antidiuretic hormone activity will lead to excessive urination and then the profound loss of fluid. So the loss of fluid will elevate the sodium concentration in the blood and cause hypernatremia. So here, the scarcity of fluid is amplifying the relative concentration of sodium. Next, we have HHNK, or hyperosmolar hypoglycemic non-ketotic syndrome. So this is similar to DKA. DKA is primarily seen, if you remember, in type 1 diabetics versus HHNS that's seen in our type 2 diabetics. But both scenarios, there is an increased or extremely high blood sugar level, and this can cause excessive fluid loss through urination in both scenarios, just like we saw with DKA. And as fluid diminishes, the sodium becomes more concentrated, again, leading to hypernatremia. So this is just a reminder of the interplay between fluid and electrolyte balances with different scenarios, in particular in the context of hyperglycemia. So these conditions just highlight the connection with electrolyte imbalances of sodium and just the fluid dynamic. So they further help to elaborate that there's a delicate equilibrium of sodium balance being intertwined with just fluid and our hydration status. So as a nursing student or a nurse preparing for the NCLEX, mastering the ability to identify early signs of electrolyte imbalance is going to be very helpful for you as you encounter test questions. So just think of numbness and tingling as an early sign of electrolyte imbalances. And the other thing to think about is keeping an eye out for things like circummural paresthesias. These mimic sensations around the lip, and this can be a telltale sign of electrolyte shifts just waiting to be deciphered for you in the scenarios that are being presented to you. So remember, muscle weakness is termed paresis, and that acts as a universal marker for electrolyte imbalances. It's a clue that can appear in various electrolyte disturbance questions that are just hidden somewhere in either your test question or your NCLEX question. So be on the lookout for muscle weakness, tingling, paresis, numbness. Those are all early signs of some type of electrolyte imbalance happening. So I wanted to put it all together for you on this one slide. If you understood the concepts that we were discussing throughout this presentation, everything can now be converged to this one slide that you can pay attention to memorizing how things flow. So magnesium and calcium oppose the prefix. So with hypostates, with magnesium and calcium, you would see excitable signs and symptoms. And you have potassium and phosphorus, which follow the prefix, except for heart rate and urinary output with potassium. So with phosphorus and potassium, if you have a hypostate, you would see low activity. And if you have a hyperstate, you would see high activity. So for example, again, in review, symptoms of hypomagnesemia, hypostates would have increased activity, seizures, tachycardia, laryngeal stridor, muscle twitching, tremors, diarrhea, nausea, vomiting, Chvostek's sign. Similar with hypocalcemia. Since the symptoms oppose, things will be sped up, and you would have symptoms such as diarrhea, muscle spasms, tetany, Trousseau-Chvostek seizures, and QT prolongation. With phosphorus and potassium, except for the heart rate and urine output with potassium, they follow the state. So in a hypostate of phosphorus and potassium, things will also be slow. Decreased cardiac contractility, so heart failure and shock would be seen with low phosphorus. Respiratory muscle fatigue, hypoactive bowel sounds, gastric atony or reduced motility, or even an ileus would be seen. And with low potassium, you would have paresthesias, flattened T waves, U waves, thready pulse, lethargy, weakness, decreased peristalsis. So phosphorus and potassium follow the prefix. So in the hypostates, things would be slowed down. Now remember, and the opposite would be true in the hyperstates. And then remember that chloride is not a primary imbalance and normally will follow sodium and potassium. So when we think about sodium and potassium and the hypo state, think of O or overload, and think of signs of fluid overload for hyponatremias, such as the confusion, weakness, headaches, and seizures. And for the hyper state, think of the E in dehydration. So in the hyper state or hypernatremic state, you would have symptoms manifesting of dehydration, such as thirst and dry skin and flushed skin and decreased urine output and fatigue and weakness and confusion, irritability, seizures, and even coma. So let's wrap things up with 2 quick questions that can demonstrate how the memory aids help us. So a client arrives to the emergency department exhibiting symptoms including agitation, tented T waves on the electrocardiogram, elevated respiratory rate, diarrhea, and muscle spasticity. So the nurse recognizes these symptoms as suggestive of which electrolyte imbalance. Is it hypokalemia, hypocalcemia, hyperkalemia, or hypernatremia? And the answer is C, hyperkalemia. We could see from the symptoms described in the question stem, including agitation, the tented T waves, increased respiratory rate, diarrhea, muscle spasticity, and hyperreflexia are elevated symptoms. So the study aid reminds us that potassium follows the hypo or hyper state, except for the heart rate or urinary output. So collectively, the symptoms all pointed towards hyperkalemia. The next question reads, a 58-year-old client known for hypertension and consistent furosemide use at home arrives at the emergency department due to unrelenting vomiting and diarrhea linked to a gastrointestinal infection. In this situation, what symptoms should the nurse be vigilant for, as they could potentially signal an electrolyte imbalance? Now, to break the question down, let's look back again at the symptoms that we are seeing in the question. So the client known for having hypertension is using furosemide at home. We know that furosemide is a loop diuretic, and with furosemide, we would be potentially losing potassium. It's not a potassium sparing diuretic. So they have arrived at the emergency department because their current problem is vomiting and diarrhea. So what can we be losing when we are having vomiting and diarrhea? Again, we could be losing some potassium. So the vomiting and diarrhea, including the use of furosemide, are pointing towards a situation where the client is probably exhibiting signs and symptoms of a low potassium level. So in this situation, it says, what symptoms should the nurse be vigilant for? So we can recall that potassium is going to follow the hypo or the hyper state. So we're looking for things that are going to follow the hypo state because we're anticipating this client has hypokalemia. The only exception in the rule is that the heart rate and the urinary output would be in the opposite direction. So would we see an increased heart rate with hypokalemia? Possibly, yes. Muscle spasticity. Would we see a muscle spasticity with hypokalemia? No, because we know that the activity follows the state. Would we be seeing hypertension with hypokalemia? Probably not, because it's also in the opposite direction, and we said that with the potassium it's going to follow the state, and we're thinking of hypokalemia. Bradypnea or slowed breathing. I like that. It's slow, it's decreased, and hypokalemia would have lower symptoms. Constipation. Well, we don't have high peristalsis. We're having a slowing probably of peristalsis leading to constipation. I like that too. It's following the same state, hypokalemia with the constipation. What about the weakness? I like that also. Weakness is also following in the same direction of hypokalemia, a lowered state. So I absolutely love B, bradypnea, constipation, and weakness. But let's look at the other answers. Would we have tachypnea? That's an elevated rate, or confusion, an elevated situation, I would say no, because we said hypokalemia. We have to follow the same scenario, so we would not have the tachypnea. Muscle flaccidity with hypokalemia, that could be, but I'm ruling out C because I would not expect tachypnea. What about hypotension with hypokalemia? Yes, I agree. It's low. It's a slowed activity with hypokalemia. That's a possibility. Dry mucous membranes, well, that's referring more to a problem with sodium, right? And dehydration. So probably not. And then with irritability, would we be seeing irritability with the hypokalemia? Probably not. So we would be able to eliminate choice D as well. And we are comfortable with our choice B for the answer. And answer B is correct. We would see bradypnea, constipation, and hyporeactive reflexes. So in scenarios involving potassium loss, such as persistent vomiting, diarrhea, and the use of loop diuretics, hypokalemia can result. And symptoms to look out for include bradypnea or slowed breathing, constipation, weakness, or muscle flaccidity. So the symptoms of hypokalemia are following the study aid, and the hypokalemic symptoms follows the hypo state with a slowing down of the activity types and the symptoms that we saw. So my aim today was to go over the general concept so you can get the most test questions right. So in conclusion, I believe that you should be able to do that as long as you memorize the minimum requirements, which are the different levels for the electrolytes, and you study the memorization aids in following the hypo versus hyper states of the different electrolytes. So please, if you found this information helpful and it has helped you to understand electrolytes much better, please give this video a thumbs up and subscribe to the channel and share this channel with your nursing colleagues. And I will see you in the next video.